Hi, this is Hadi Lisha, cardiologist at Ascension St. Thomas Heart in Murfreesboro in Nashville, Tennessee, coming to you from ACC Early Career with the educational pearl of the day. I'm going to try to get you 10 takeaways from the valvular heart disease guidelines that were published in December of 2020 in the Journal of American College of Cardiology. So hopefully in less than 3 minutes, we'll go through 10 takeaways. Point number one is the importance of the multidisciplinary heart team in the management of severe heart disease patients. Number two would be in patients with atrial fibrillation. The threshold for direct oral anticoagulant is getting lower and lower. So except for rheumatic mitral stenosis and people with mechanical valves in general, the direct oral anticoagulants are reasonable, and it will be a discussion of risks and benefits with the patient. Point number three is that the symptoms of valvular heart disease are classified into 4 categories, which is similar to the heart failure symptoms: A, B, C, and D. A being patients at risk for valvular heart disease, B being everything less than severe, C being severe but asymptomatic, with C1 and C2 LV, depending on the presence or absence of LV dysfunction. And of course, stage D is severe symptomatic. Point number 4 is whenever there's discrepancy between clinical symptoms and imaging studies, it is recommended to proceed with further testing. Whether this is non-invasive or invasive depends on the case, but the importance of symptoms is very, very focused upon, especially nowadays where imaging studies are ordered very frequently. Point number 5, regarding aortic stenosis, the treatment should be focused on patients who are symptomatic or who have LV dysfunction, with the exception of very severe aortic stenosis, critical aortic stenosis. So there's also a point of lowering the threshold for an intervention for asymptomatic severe aortic stenosis patients based on stress testing, biomarkers, and if there's rapid progression. Point number 6 is shared decision-making regarding aortic stenosis treatment in terms of transcatheter versus surgical aortic valve replacement, and in surgical, whether it's bioprosthetic versus mechanical prosthetic valve replacement. This should be discussed based on the risks and benefits and depending on multiple other factors. Point number 7, in valvular regurgitations, again, the interventions are mostly based in patients who have symptoms or evidence of long-term mechanical dysfunction secondary to volume overload and structural remodeling. The threshold for an intervention for primary degenerative MR is getting lower and lower, and obviously this would be surgical. Point number 8, on the same point, the mitral clip is not first choice for degenerative MR, it's second choice. It would be in patients with prohibitive surgical risk, but mitral clip is a very reasonable choice in secondary mitral regurgitation in the setting of heart failure on guideline-directed medical therapy still having symptoms. Point number 9, in patients with severe primary tricuspid regurgitation, that would be patients with pacemaker-induced tricuspid regurg or AFib with secondary atrial remodeling, surgery is very beneficial, especially before there's evidence of right ventricular dysfunction or dilatation. And finally, point number 10, percutaneous structural interventions are pretty effective and recommended in non-thrombotic degenerative prosthetic valve dysfunctions or paravalvular leak if there's no infection. Thank you. I hope you enjoyed it.